because I do tons of coaching, meaning people record sessions with clients, and I listen to them using a standardized instrument, and I code them. And what I know, even for people who are just straight out of graduate school and are really green, that even they have some skill already in one or two areas. They're not necessarily competent, but they have some skill. So I assume that from you all, that all of you have some skill, but I bet that none of you have all of the skills and knowledge that you need in terms of MI. So if you're okay with that and are willing to start there with me, then I think it'll go really well. So essentially, I need you to sort of say, I'm a beginner today, or maybe a minimally competent beginner. I'm going to talk about not just motivational interviewing. I'm going to talk a little bit about the trans-theoretical model to start with. How many of you in this room know the trans-theoretical model? If you came out of this graduate school of social work and you didn't raise your hand, you have a problem. So the trans-theoretical model is a model of intentional behavior change. It's a useful model to think about how people change. When I first came to Search in '94, it was at the beginning of the crack epidemic, we're really in the middle of it. And even though we had 12-step on site, we had people that were coming in high, we had polarized relationships with clients, and they didn't trust us with telling us about their substance use because they thought there would be negative consequences, which there would have been. It was good reality testing on their part. But we were really very ineffective in working with that problem. I had known this guy, Carlo Di Clemente, for about 10 years at the time. Carlo was one of the developers of the trans-theoretical model along with James Bruchaska. And so I talked to him and said, help, what do we do? And so it was a model that he had developed, and so we started using it and found that it really shifted our relationship with our clients and gave us a framework to begin to understand where people were in terms of behavior change, not just substance use, but behavior change in general. And then if we could know or understand or guess which stage of change they were in, then we could design an intervention appropriate to the stage of change. And so what that means is that if somebody doesn't think they have a problem with drinking, even though they might be drinking a fifth a day, that I'm going to have a different intervention and a different way of talking with those folks than I would for somebody who's been in treatment and is going to 12-step and trying to stay sober. And yet oftentimes we know that they're different, but we don't know how to work with people depending upon which kind of stage of change they're in. Particularly if we do something that's a little more psychodynamic, we may not, if I take this off, then I'm in trouble with the mic. So if we do something that's more psychodynamic or analytic, that may not even really be something that we've come across in our training. I have a friend who's been a master's level, I have a couple of friends that are master's level therapists, probably for 30 years. And when it comes to working with people around substance use or behavior change, they are really stuck. So the trans-theoretical model grew up about the same time that motivational interviewing did. And they were both tons of research. They did projects together like Project Match, where both of those models were in play. I find it really helpful. So for those of you who have studied the trans-theoretical model, then in some ways you have a little bit of an advantage of people who haven't studied it when it comes to learning MI, because aspects of MI really map onto the TTM really well. So how I want to I want to talk briefly about that after we do an exercise. So you guys all have an exercise that you should have gotten at the front door, and it's two-sided. It's called the personal change exercise. And I want you, so it's always easy to think about our clients, the other. What I find is that we have these expectations for other people about how they should be, what they should do. Well, just stop. I mean, really, just stop. Yeah, I know it's hard, but just stop. And so I think what's helpful in workshops like this is if you think about your own behavior changes that you've made in the past or that you're struggling with now. I've been struggling to lose, I don't know, 20 pounds, 25 pounds now for, gosh, almost that many years. I've made progress, though. So in this, I want you to think about a change you made. It could have been a long time ago. So when I'm talking about that, I'm talking about things like maybe it was a decision to leave a job, maybe it was a decision to stop beating your kids, get out of an affair, stop talking smack about your friends, eating better, exercising, stopping smoking, stopping drinking, cutting down smoking weed every day. All those kinds of things are behavior changes. So I want you to think about one that you've made and take about 5 minutes to answer the questions on both sides of this page. I've seen periodically people just go through really quickly and put bullet points and knock this out in about a minute. So I'm asking you to be a little more thoughtful about this. And I won't have everybody in the room share, but I will ask for 1 or 2 of you to share. has the ability to be brief. Yeah, go ahead. It's Erica, right?
Yes.
How did I know that?
I tried to lose weight.
Yeah, you want to stand up, please?
Sure. I used to be very heavy, more than 200 pounds. 10 years ago, I tried to lose weight. I looked for help. At first, I realized I couldn't do it because all my life I've been heavy. I looked for help. And then I changed my relationship with certain foods, like stop eating them.
So back up a second. Can I say this again? I'm so sorry. So how did you decide to make the change?
It was affecting my health. I have a lot of diabetes and heart disease in my family. So one of my cousins had to cut his foot.
Right.
So I thought, that's me in the future.
Yeah.
So that's how I start thinking about it.
Right. So you got scared.
Yes.
Yeah, because other people in your family had experienced diabetes from being overweight, and then it became a visual impact for you. Okay.
Then I tried to do it on my own, and I couldn't. And realizing I couldn't do it on my own, I asked for help. and that's what happened. Yeah.
And the second page?
Second page.
The other side? Flip side?
Oh. I just answered the first page.
Did anybody else do the second page? Okay, great. All right.
Oh, I decided to make it 10 years ago. What change did I make? I stopped eating flour and sugar. And what people eventually influenced your decision? I started attending Overeaters Anonymous, and that's the people who helped me.
Oh, great. Good. Okay. Someone else? Yes.
Well, mine's kind of a different,
I'll let you stand up too. You can stand up.
in terms of change I made, I mean, not that you would know it, but anyway, I started to go to the gym a couple times a week about a year ago. Okay? And if I think about what really got me there, and this is just sort of a funny story, I tell people it's true, is I moved to the area, got a new place that I rented, and I didn't know that the hot water was connected to the gas, okay? And the people couldn't connect the gas for like 2 weeks. So I didn't have any hot water, okay? So it wasn't that big of a deal for myself, but I was having company come over for the weekend, and I was like, oh my gosh, I don't have hot water. Well, there's a gym, Lifetime, not too far from me, so I looked up, and you get a free month membership, you know, and I thought, okay, that's what I'm going to do. So I really just went there to use the shower. And I had to stay with it in large part because where I work, they do reimburse part of your membership. So it was really quite reasonable. And there was no contract. So I thought, what the heck, if I like it, you know, it's this amount of money a month. If I don't like it, I'll just quit. So that's really how I got going.
Yeah, but how did you get from the shower to the workout space? You could have just walked in that door.
The first couple times I did. I seriously did not. The first 2 weeks, that's all I did is use the shower. And then I thought, you know what, I'm just going to try to do the bike, maybe do the treadmill. And then I did talk to somebody. She was very sweet. And really, she was sort of a key player for me. She was a younger person, and she just saw me there. She kind of reminded me of my daughter. And she just was, you know, she was there a couple of times I was there. She was very, very kind to me, you know. So she was instrumental, I think, for me.
Yeah. So it wasn't so frightening. It was,
Exactly.
in fact, it was kind of reassuring.
Exactly.
That you could do something.
Yeah.
Great. So, okay, so you're an aberration. So I'm going to go back to you. How long, so these two questions, how long was it from the time you first became aware that your weight was an issue to the time you began to try to change it?
2 years.
2 years, okay. And then how long was it between the time you first began trying to change and when you finally completed it and felt it was all behind you?
I started 10 years ago and it's never behind me.
Okay, all right. So you're still working on eating right and not eating wrong foods and...
But holidays is a big problem. And if I think I have a little bite of this. It's really hard to stop it.
Yeah.
It takes me months. Last time it took me 2 years to stop eating certain things.
Yeah. Okay, great. So the point here then is, for most of us, being successful at behavior change takes time. Did most of you see that in yours, in your behavior change? So it often requires multiple attempts, sustained attempts. Most of the change that we do doesn't require treatment. I mean, we make changes all the time. We make decisions to leave jobs, leave marriages, leave relationships, start exercising. And sometimes we want some support, some formal support in the form of treatment. All behavior change, though, consists of self-treatment, self-change. So we're the ones making the change. Even if we went into treatment, they're not going to make the change for us. We're the ones that have to make the change. And when we do it, it involves changes in other parts of our life. So if we have a spouse who drinks and we're drinking, and we decide to stop, it affects the whole family, potentially. When you're trying to eat more healthily and not eat sugar, what do people do? Sometimes they keep bringing it, but other times they're really sensitive, you know, that she doesn't eat that, and let's try and prepare something that she would eat, you know. So there's a context in which our life occurs, and when we make these changes, it can impact other areas of our life. So when you're working with clients, then how do you know that people are in that early stage of change where they're just thinking about it, where it's in their head, it's in their body, it's not anywhere in action at all? How do you know? What do you hear from them that shows you, that tells you somebody's thinking about making a change? What kind of language do you hear from them?
So if someone has an alcohol abuse problem, for example, they may say, I want to stop drinking.
Okay, I want to stop drinking. Okay, yeah?
You may need to quit smoking.
Maybe, I like that. Maybe I need to. We don't have a, what do you call this thing, flip chart? We don't have one of those. I asked for it, but we don't have it. What else? Yes?
How did it affect their life, you know, the effects on their life?
So they start to tell you about how a certain thing is affecting them. Yeah, I was in bed this morning thinking, you know, if I don't get back to doing these back exercises, these muscles are going to wither away. And then I won't be able to stand in front of people for 6 hours and do a training. Yeah, exactly.
When they start to talk about needing or wanting something different, it's at least opens up the conversation for change talk.
Oh, good. She's using my language here. Who else? Yeah.
Expressing worry about the way they've seen other people in their lives. This is, you know, like alcoholism, how alcoholism has affected other people in their lives.
Right. Yeah. Yes.
Ambivalence.
What do you mean by that? For those in the room who don't know that word.
Well, they start questioning themselves, you know, their behaviors. They start asking themselves, you know, are they doing the right thing, or should they continue the same behavior, or should they try to work on stopping? They're on the fence.
Right, they're on the fence. Oh, good. That's such a nice segue into the next slide. So this is an old slide, and it's kind of funny, but over here we have this guy. I'll try and mix the genders up here, but anyway, this guy, and it says pre-contemplation. So again, we're in stages of change right now, trans-theoretical model. So this person is going like, I'm saying his back is towards you. It's like, no, I don't have a problem. I'm not thinking about changing. I'm not going to do anything. Leave me alone. Probably some of your friends and family feel like that with you at times, right? I'm not doing it. Leave me alone. Stop badgering me. I see some looks of recognition. So again, this is a really old slide, and I want to give a little attention to it. At the bottom, it says this word called denial. It's a word we don't use in MI. It's a word we don't use in the trans-theoretical model. We also don't use this word resistance anymore. So I used to smoke when I started smoking when I was in college, and it was a time, it was 1970. I went back and Googled it yesterday. 40% of the population smoked in 1970. That's a lot of people. And so you could smoke on airplanes, you smoked in movie theaters. It wasn't necessarily acceptable, but people did it. And there were always some people who were kvetching because you were sitting next to them and smoking. So if you had said to me, you're in denial, you're resistant to changing, it's like, no. I mean, I had a certain naivete about my behavior. And to label me as being in denial or label me as being resistant, it was like, no, I don't see how this is a problem. I mean, genuinely, I don't see it's a problem. Now, it might be a problem for this person sitting next to me, but it's really not a problem for me. So sometimes I think what we do, so part of, in the TTM, one of the things I like about it is one of the first things you have to do is help raise the awareness of that person, that this is potentially a problem. It may be a problem for others. How do you get them to see it as a problem for themselves? And that takes some work sometimes. But I like to presume some degree of innocence here, as opposed to this blaming sort of thing, this naming and blaming. I am more inclined these days to think of it as a lack of skill on the part, and maybe a lack of awareness on the part of the therapist or the counselor as to this person's stage of change, and maybe the therapist's level of frustration because they don't know what to do with that person. So it's easier to blame them, make them the bad guy, label them, rather than say, here's what I've got. I've got somebody who's in pre-contemplation, not even thinking about change, or maybe just a smidge. And they may stay there. How do I work with this person? What do I know about how to work with people in these earlier stages of change? This next one, what is your name in the back with the baseball cap?
Chris Sykes.
Chris? All right, so Chris called it. This person's sitting on the fence. Ambivalent. Somebody else mentioned the word earlier, maybe. Was that you? One of you? Maybe. So we'll talk a little bit more about this, but there's ambivalence. So once somebody moves off this position of, I don't have a problem, I'm not worried about this, I'm not concerned about this, I'm not thinking about making a change anytime soon, the next place might be, well, I am a little worried about it. I'm a little concerned. I've had a wreck. My insurance has gone up. I've had multiple tickets. You know, I still like really driving fast. And I'm not ready to do anything. But, you know, it does worry me. So you've got some ambivalence there. You've got something to work with. They're not ready to make any kind of plans. They're not ready to make any kind of changes, but they're starting to think about it. So for you, with your own behavior change, think about how long you had to think about it before you were ready to do something. There's a really beautiful article by this guy named Roy Baumeister, B-A-U-M-E-I-S-T-E-R. He's done a lot of research on willpower. But he wrote this article a long time ago called The Crystallization of Discontent, which is, gosh, it's just a beautiful article. And what he talks about is sometimes you have these pieces of discontent in your life. It could be about your weight. It could be about your fitness. It could be about, who knows. It could be about a bunch of things. And they bother you, you know, but they don't necessarily bother you sufficiently. And then one day, out of the blue, who knows why, it can't be forced. One day, something shifts, and all of this discontent comes together, and you say, I'm out of here. I'm not doing this anymore. So it's a beautiful article to read if you can find it. So it can take a while in contemplation. The next step, once we start hearing not change talk, but commitment talk, is this stage of, okay, I'm ready to do something. I want to do something. I don't know what exactly. I need to explore this. So sometimes we skip straight from somebody's commitment language straight into action. It's not a wise move. So that's a stage, preparation is a stage we really need to put some attention to. There's a pretty easy read, if you're into easy reads, on the trans-theoretical model called Changing for Good, paperback. It is nonfiction, though. And they go into quite a bit more detail on all of these pieces. Then there's action. Action can last typically 3 to 6 months, although for some of us around weight loss, it can last longer. Maintenance is where this new behavior really has become a part of your life, the old way of being. So for me, I stopped doing sugar also, not sugar completely. I stopped doing desserts. So I will do breakfast spreads, but I will not do desserts. And you know, watching that, you know, when I first stopped, and you know, I focused a lot also on behavioral therapy with our staff, and so, you know, watching those urges come up, watching the craving, and then over time really seeing that I can look at cookies and have very little of a physical reaction. So that's where the maintenance is, over 6 months, where the new behavior really gets integrated into your life, and you don't get such a charge, such a trigger, hopefully. And then last is relapse and recycling. All right, so then, where do we go from here? So here's the language. You already identified it. No, not me for pre-contemplation. Well, maybe, baby for number 2 for contemplation. 3 is preparation. Okay, so now what do I do? What do I do now? Uh-oh. Okay, and then action. Okay, I'm ready. Let's do it. And then maintenance. Wow, it was possible for me to do this. I was able to do it. So then in MI, we don't do a lot of digging into somebody's past. We do a little bit, but it's, there's a specific reason why we do that, which I think will become more apparent to you. We are focused more on the present, on the future, and we listen to language in a particular kind of way. I think sometimes we get caught up in people's stories. You know their stories, but we get caught up in them. In MI, we listen differently, and we're listening to the language itself. There's a guy out of UC Berkeley. I started studying his work back in '82. His name is John Searle, S-E-A-R-L-E, and you don't want to read him because he's philosophy of language. And so his model that he developed was called the taxonomy of illocutionary acts, or speech acts. And some of the work in MI, particularly over the last 10 years, change talk, commitment talk, has come out of, some of the research has come out of the work by another guy, Paul Amrine at Columbia, who has focused on speech acts, commitment talk specifically, and some change talk. So we're listening for language, the kind of language that people are using. So we're listening for ambivalence. Can somebody close that door? So we're listening for this uncertainty. Reasons for, reasons not to, reasons for doing the current behavior, reasons not to do the current behavior, reasons to make a change, reasons not to make a change. We're listening for that ambivalence. We're listening also for pushback, discord. Sometimes you hear it with your ears, sometimes you feel it in your body. I walk with a friend of mine, usually every Saturday morning at Memorial, and it's dark, and we're walking, and you know, she'll say something, then I'll say something, and I try not to be a therapist with her, so, you know, I'm just my normal jerky self, and I can feel it when I say something. You know that when you say something to a friend or a family member, and it's just like it comes across the room almost to hit you, you know, because you said something that produces this pushback, this discord in the relationship. So in MI, how we think about that is that, or even in the TTM, one way to think about it is you're missing the stage of change that somebody's in. You're too far ahead of them. If you're getting pushback, it may be because you're missing where they're at. You're wanting them to be somewhere where they're not. You're trying to move them too quickly. Some of the other language we listen for is this, what we call sustained talk. So how do you know when a client isn't interested in making a change, or a family member, or a friend? What do they say to you?
No way.
No, who said that? You said no way? Okay, no way. What else?
You don't have a problem.
I don't have a problem. I'm fine, yeah. Yeah. I don't need you to, tell me what to do. I don't need your help.
But never I'm ready.
Yeah. Or they may not say much of anything, but you can't seem to get any traction here in the conversation with them around a particular kind of behavior. Then there's change talk, which we'll spend a little time on later, and then commitment talk. Commitment talk is what you want to hear if you're on the altar. Or if somebody says, you know it's going to be raining at 5 o'clock this afternoon, and somebody says they're going to come pick you up. There are people that you would trust with that, you know, and other people that you know they're probably going to be 45 minutes late. You're not sure this person would even show up. And so commitment language is the kind of language you're wanting to hear from somebody who's going to pick you up in a thunderstorm or on the altar. So there's stronger commitment language, weaker commitment language. What we're doing is listening, not just for tick counts in a session. Well, shoot, they gave me change talk 6 times. That must mean this is going really well. So we're not just doing that. We also are always listening for not just the words, but the emotion, the behaviors that correspond with that.
Sorry, girls for meds. Alarm on you.
Okay. All right. Now I'm lost. Okay. So we're listening for more than just the words. We're listening for the meaning, but we're also listening for this. So we're listening for the strength of what is being said. What you want is in a session for maybe there's weak change talk. Maybe there's some ambivalence, a lot of sustained talk, but some change talk. You want, at the end of the session, for there to be more change talk. You want there to be stronger change talk. If a client comes in giving you change talk and they leave with sustained talk, that's going the wrong direction. Questions? Yeah.
Could you give some examples of what that would look like for specific behavior, and in terms of like the weak commitment versus strong commitment, and just something more that you might hear from a client with a specific behavior?
So those are 2 questions, right? Yeah. So somebody might come in saying, I mean, I think you'll see this in some of these videos that we're going to, that I'm going to show this morning. Let's see, just a second. You know, I've fallen off my diet again. I'm just trying to make up a scenario right here. And I've been smoking weed again, and I'm smoking cigarettes again. And I know I shouldn't be doing that. So one of the first things you're going to do is you've got to identify target behavior. You've got to work with the client to identify target behavior. So you have 3 things right there that got thrown out. Which of those is more important? Which of those would you like to focus on? So when we talk about stages of change, or when we do motivational interviewing, there always has to be a focus. There always has to be a target behavior. Sometimes what I hear people say when we're talking about the TTM is, oh, he's in pre-contemplation. Well, it's like pre-contemplation about what? You can't have a global, this person's in pre-contemplation. It's always around specific behavior. And so if I were working with my friend around that, I might say, which of these, concerns you the most these days? What worries you the most? And so that's an open question. By asking him that and using the word worry, which I would do with my friend, then he would start giving me a little something. And then I would build on that by reflecting. So, so you were doing really well with Snap Kitchen for a while. And you seemed to really like that. Yeah, I did. I really liked it. It was easy. I didn't have to make any decisions. And I wish I were doing it again. And so then I would reflect on that and say something like, so you've been thinking about getting started again with that? And he'd say, yeah. And I'd just keep building on that. So in terms of commitment language, there's a chart. I don't think I put it in my in the slides. So commitment language, my staff, so because I got a lot of training in commitment language back in the 80s, my staff will come in and they'll say something like, I think I might be able to possibly get that to you on Friday. I'm not really sure, but I think I might be able to do that. Well, and they don't know, that I know what they're doing right there. So then I would work with, my staff are different than I would work with a client around that, but, so the stronger is, yeah, I can get that to you by Friday. Probably I can get it to you by Thursday. Close of business, 5 o'clock. Yeah, I'll let you know if I've got any problems, but yeah, I can do that. Very different tone, very different way of speaking. Yeah. Some people are really used to using weaker commitment language. I mean, they try to hedge their bets just so that they won't be seen as lying. I've had some 12-step people say that they were told they could never make promises and commitments. I don't know if that was just this one person. I don't know. Again, we're just skimming here today. So let's dig a little more deeply into what time have we got? So we're going to take a break sometime, maybe. Would that be commitment? Oh, I said that. You guys are quick learners. All right. So this kind of work on decisional balance came out of the research of Janice and Mann a long time ago. And, one of the ways we think about it, so who has a behavior that they've been thinking about changing? Yeah, what are you thinking about?
Weight loss.
Weight loss, okay. And so weight loss involves some sorts of changes. It could be around diet, it could be around exercise. Around exercise, okay. So this one's near and dear to my heart. Okay, so here's the current behavior, and the current behavior always be then. So my current behavior now, I used to exercise really regularly. I'd come home, and so I've relapsed big time. So now I come home and I sit down on the sofa and I read the paper. I might nibble on a little bit of food. And then by the time I finish with the paper and the mail, it's too late to work out. So here is this exercise is the target behavior for us. Currently, right now, I feel too tired when I come home from work to exercise. I really just want to sit down and read the paper, and yet I do want to exercise. So the pros are, it gives me a chance to unwind from my day, I get to really relax, I get to do something I love, which is read, and yeah, it's just some downtime. So what are the cons of that? So that's part of what I want to be pulling for. So this person has given me all these pros for coming and sitting on my tuchus when I get home from work. So what are the cons of that? Well, the negative is I never get around to exercising, and by the time I do, I'm really even more tired. And also, though, I'm losing muscle tone. You know, I don't have these abs of steel. When I go hiking in the mountains, which I love to, you know, there are all sorts of reasons why this is not so good, why this. If I was to make the change, so here's the other side, if I were to make this change and start exercising again regularly, what might be the benefits of that? I'd be in better shape when I go hiking, I'd feel better about myself, I'd have better muscle tone, my back muscles would be stronger, my abs would be stronger. This is really important for my health as I age. I want to have good core strength so I don't tumble over, those kinds of things. If I were to make a change, what might be the not so good side of that? Well, it'd be harder for me to get the paper read. Gee, I'm not really sure. So that's what we do with ambivalence. Ambivalence is really this weighing the pros and cons. The pros and cons on both sides, except. Here's where the dry marker board would be helpful. This quadrant up here, which is the reasons I love sitting on the sofa and reading the newspaper and doing my mail and nibbling, this piece is the sustain talk. And in MI, what we want to do with sustain talk, we don't want to ignore that because that's rude, disrespectful. But we want to soften it. Where we're going to get our traction is not by asking this person, what do you love about sitting on the sofa and reading the newspaper? Look, I'm already there. You don't have to strengthen that. These other three quadrants are the ones that we want to be working on. Does that make sense? Yeah. So we don't want to strengthen sustain talk by asking a lot of open questions about it, reflecting on it. We don't want to totally ignore it, but our focus needs to be here. Oftentimes, I think what happens to us when we're talking with friends, when we're talking with family or clients, is they give us negatives around behavior change, and we get hooked, we get snagged, and we go that direction with them. And that's not what we want to do in MI so much. We really want to be moving in the direction of change, not building the case for not changing, not building the case for sustaining the current behavior. So we don't ignore sustain talk, but we really focus more on getting some change talk going. And then once we've got it going, working with it. What questions do you have? I know there are questions out there. I'm seeing it on some of your faces. Yeah.
Let's say in your case,
Yes.
We're talking to you and you have that precious time at that night. I don't mess with that and I just see where in the other parts of the day can accommodate.
Right.
Or do you try?
But see, you've gone into problem solving already. Yeah, so we're not there. Problem solving would maybe show up in preparation. So I'm still ambivalent. You've got to strengthen my change talk, my reasons for change. So the desire for change, so this other part here has to get stronger. Let's see what we can do here. Let me show you. So this is an aggressive, did somebody else have a question? Yeah.
You said something about softening the sustain talk. How do you do that?
You somewhat ignore it. You don't turn your attention to it. You know it's there, so you mention it maybe once. They may have given you 5 reasons. I gave you 3. I'm tired, want to sit down and read the paper. I read it 4. Snacking. So you might, when you gave a summary, you might just mention 1 or 2 of those. You wouldn't give all 4. You're not going to put a lot of them. Yeah. So this is a slide that's a poor quality slide, but so this is aggressive driving. Do you know these guys? Big pickup trucks on the loop. You know them? All right. So this is a study. Yeah.
I'm just curious. Is there a way to lower the lighting?
Yes.
To be able to. Thank you.
It's a bad slide, though, still. The thing is, though, this is a study that was done on aggressive driving, but it is not unique to this. Oh, that is better. Better? So there are many other kinds of behavior change that you can look at, other sorts of studies that have very similar profiles. Almost identical, whether it's wearing condoms for men, whether it's crack, whether it's, it doesn't matter. They really wind up looking like this. So in this, good deal. So here's pre-contemplation, not even thinking about change. Over here's contemplation. And then here's this ambivalence. So in this study, what they found was these aggressive drivers really love driving fast. They love driving fast. So and they've got plenty of reasons for it. Testosterone makes them feel important. I heard a laugh from my male person. Hi, nice to see you. Reasons for change are really low here. That's the yellow line. So this person is not going to make a change unless the reasons for making the change increase sufficiently. And the reasons for the current behavior have to decrease. So you see the reasons for driving fast still stay the same. And in ambivalence, what has to happen is the reasons for making a change, whether positive or negative, have to keep going up and increasing in strength before this sucker starts to go down. And then it drops in contemplation, and then here's preparation and action, so then it goes up a little bit. So what you've got, though, is the reasons for changing are higher than the reasons for continuing the old behavior. And you really want them to be this far apart. You want them to be so far apart. Unfortunately, what happens in substance use is, so preparation, action, and maintenance, particularly maintenance, wind up being close together. So if you're looking at something like crack or tobacco, they're really close, which means the temptation is very high. That's one of the reasons that motivational interviewing typically in the past has been used for people in those earlier stages of change. Pre-contemplation and contemplation. You usually use something like CBT or behavioral therapy for preparation, action, and maintenance with maybe an MI coaching style. Yeah, let me just, so for addiction, what you have to really listen for, even if somebody's in maintenance, is you have to listen for that ambivalence. And then, even if you're using CBT in action and maintenance, when you hear that ambivalence, where something seems rotten, a little off, then you can go back to using the really MI more fully again, pulling for change talk. Yeah?
I work in a medical setting, so a lot of the nurses that we work with, you know, for nurses it's, why aren't you making this change?
Right.
You're diabetic, you need to, you know, stop eating this and this and this. So a lot of it is guilt that they're bringing to the table.
Yeah.
And I struggle with the cons, not making the patient, not leading so much to the guilt.
Yeah.
I think there's enough guilt in this world already.
Yeah.
How can we kind of encourage to talk about the cons without necessarily making them feel guilty?
Sometimes they'll start giving them to you. I mean, when we were talking earlier, when you guys were doing your, so we'll talk about that a little bit later. It's the open question part. And we'll talk a little bit more about that this afternoon too, around integrated care. Some of it is listening too. I think about homeless people who are living on the street and they may not be ready to leave the street, but they will tell you about the ants. You may know that they've been beaten up before, all their belongings stolen multiple times. If they were a female, of course, they were raped. So you know there are some negatives, the mosquitoes. And so you listen for those. You listen to what's underneath. You observe. And so sometimes you can make a guess. Or sometimes you just, you know, may ask more directly, you know. You want them to bring it forward, though, and that's the best way. All right. I think, so here we are, Discord again. We've talked about that, so I'm not gonna, I want to show you a video before we take a really brief break. So sustained talk, we've already talked about that, not thinking about changing, status quo, keeping things as they are. Change talk is, what you're listening for is importance. Why is it important? So often we talk about it as a darn. Desire, reason, and need. I know that doesn't spell darn. Darn is D-A-R-N. I'm leaving the A out right this second. So you're listening for what you guys already identified. Needing or wanting something. Maybe I need to. Worry. If somebody's worried about something, they really oftentimes would like it to be different. So you're listening for why is it important for them to make a change? What are some things you can use that they don't like about the current situation? Those are reasons. Those might be desires. So you're listening for that. The other thing that has to be there is ability. They have to have this confidence that they can actually make this change. It could be so important to them like their life depended on it, important, but they have no confidence. I've been through treatment 12 times. It hasn't worked. So you have to break that apart and play with that. That's really rich there. And their confidence levels may be low. So anyway, that's what you get in a 2-day workshop or a 3-day workshop. You get more work on that. I think what's important to realize is it can be incredibly important for somebody. Let's think about a relationship. It can be really important for somebody to leave a relationship. They could be confident that they could do it, and yet not ready. So you have to, yeah. Can you think about times that's been so for you? All right, so we're going to listen to, hopefully, a video. These are 2 videos. If you get the slides, there's a slide, I think, that will tell you, there's some good YouTube sites that have MI stuff. There's some really not so good and even bad MI on YouTube, but there are some good sites that I've put down in there. Do I want to show this now? No, I don't want to show this now. All right. So let's do a little bit of MI Spirit first, and then I'll show the video after that, which means I'm in the wrong place. MI is based on this work of Carl Rogers. How many of you, I took a course, an individual counseling class, my senior year in college, and it was all Rogerian. We used Carl Rogers' books. How many of you were fortunate enough to do something similar? We have a couple of you in here. All right. So Rogers did his work, client-centered therapy work in the late 40s and early 50s, was when that model was being developed. It came out of humanism, not secular humanism, but humanism. And Bill Miller was doing, early in his career, was doing a research study with alcoholics, and he was using behavioral therapy as one intervention. The other intervention was client-centered. And the client-centered got better results. I think there are multiple reasons why, possibly, but he really became interested in why that was, what the client-centered approach had to offer. And so he built this model out. Carl Rogers' work is considered to be pretty non-directive, just kind of going where the client goes. Although Bill Miller says that if you look on YouTube and watch some of these clips of Rogers, that you will see some of them, there is some directiveness going on there, some direction. What motivational interviewing did was take that client-centered approach and add a guiding aspect to it, a guiding direction. Tons of research has been done with this, over 200 randomized trials. You're able to establish fidelity. So, one way to remember this MI Spirit is by the acronym called PACE. MI has 3 editions out now. The 3rd edition, if you want to read, you need to read the 3rd edition. I think there's like 70% of the content really changed Bill Miller really makes a lot of, and Rolnick, there's lots of research always being done with MI, and so they really weave that research into their understanding of the model and their development of the model. So when we talk about MI spirit, every one of these aspects can be operationalized. And so what we do at Search is we have this as our client-centered, as one of our core values for our agency, and people get evaluated twice yearly on how well they adhere to these values. There are a lot of organizations, hospitals, schools, you name it, who say they're patient-centered, client-centered, whatever. I bet the majority of them have never gone back to Roger's work and even looked to see what that meant. My staff come in, new staff, and say, well, I'm client-centered and I care about the client. Well, client-centered isn't just caring about the client. If you were getting coaching and had somebody coding your sessions, one of the things that you would be being coded on is your ability to speak in a way that's consistent with this client-centered approach that Roger's developed. So partnership. Sorry, I don't have another kind of watch, but clock. You got two experts, two of them. You're hopefully an expert, maybe minimally competent, maybe competent in some areas. The client is the expert in themselves. And oftentimes we don't believe that. If you would only do what I tell you to do, life would be so much better. Really, if you just did this, so we have to restrain ourselves from this wanting to tell people what to do in MI. In a partnership like this, the client talks more than you do. But that doesn't mean that you can let clients monopolize. You still have to show up too. You just want the client showing up more than you. There's a way in MI, there are two ways to give advice, suggestions, feedback. One, you have to come to a workshop and find out about, or read the book. And then secondly is you have to ask permission. And you have to wait for them to give you permission. Acceptance. So I assume that all of you in this room have heard about unconditional positive regard. Comes from Rogers. So you have to believe in the absolute worth of people, the person sitting in front of you. And I think probably most of you do, otherwise you wouldn't be in this field. You have to be respectful of their autonomy. Which means, so a lot of what we say might be, it's up to you, it's your choice, no one can make this choice for you, no one can make this decision for you. Really putting it back in their court. What do you think? What ideas have you had? What have you been thinking about? What are your options? So again, putting it back on the client. Not in sort of, in a really respectful way. And acknowledging and really believing that it is their option not to choose. It's really, Empathy, which we show that so this is not a traditional definition of empathy. So in MI, we show our empathy by being spot on with our reflections, really listening to the client and reflecting back accurately what they've said. not just in words, but also what's underneath what they're saying, so that they feel heard. And then affirming. So in MI, this is not praise. Affirming is positive reinforcement. So it could take something like a value. It might be something that you feel like needs to be strengthened somewhat in order for them to be successful, like you really made a big effort getting here today, in spite of the rain. Or it might be, it's really important for you to be the kind of person that people count on. So something that you want to see strengthen, that you think is going to be so important to them going forward. You'd like to be able to do this once at least during a session, maybe 2 or 3 times. It always has to be genuine though. And I'm not talking about praise. Some people are praise junkies. And then the client just, you know, what do you do when somebody's too effusive with their praise? You just kind of discount them. So the other piece, compassion. So where this came from, it really grew out of the empathy. So used car salesmen, maybe not even used, car salesmen got hold of MI and started using it to manipulate you and me. And so Bill Miller said, you know, we need to do this. So anyway, he added compassion. And he says compassion in the way that the Dalai Lama means compassion, the way Sister Teresa, Mother Teresa rather, feels about other people. That real tender-heartedness. And oh, yeah. Of course I can. Yes. Thank you for asking. Yeah. All right. And I think the last one is evoking. So this requires the use of open questions. Many of you are prone to closed questions. You may not know it. This requires that you ask open questions, and it is drawing forth, bringing out, but it's oftentimes really trying to pull for change talk, trying to pull for the reasons that somebody dislikes their current situation, hopes and dreams that they have about the future, what they would like to see instead. So asking open questions to evoke, to pull from people what they'd like to be different. Your main job. So my staff, so when I have new people come in, again, many of them recent graduates, they think their job is to help patients our clients rather, set goals and give them resources. Kind of make sure that they follow through. So that's not what we do. Our job, in my mind, is to help people make behavior change. And there's a big difference there. So then the main task for them is to elicit and strengthen change talk and commitment talk under MI. What is not consistent with MI and a client-centered approach is you giving unsolicited advice. Sometimes reflections can get so long, they stink of sermonizing. Trying to persuade, giving directions, emphasizing abstinence. There is a way to recommend that, but again, you're not going to get that in this couple of hours. Confronting is not consistent with MI. Not at all. And you asserting your authority. And in the past, we used to say closed-ended questions. Closed-ended questions are not forbidden, but you get more from open questions, usually, and from reflections.
What do you mean by powerlessness?
In 12-step, people are told that they're powerless. So I'm not saying there's anything wrong with 12-step. That's one model, this is a different model. All right. Okay, the question is, do we take 10 minutes now or do we watch 2 videos?
Video.
All right. She who speaks first. Uh-oh.
I'm sorry.
Like 10 people at the same time, right? All right. You better hurry or you're going to miss the video. All right, so what I want you to be listening for, what do you think? Should we take a break? Yeah. All right, 10 minutes only. All right. So we want this half of the room listening for we want this half, these two upper layers here, listening for sustained talk from the patient. What you guys are listening for change talk. Desire, ability, reason, or need. Okay? You guys listen to the physician, and you're listening for is what the physician says in accord with client-centered and MI-Spirit approach. And if not, why not? Okay? See if we can make this sound big enough.
Ability to talk to them about how second candidates will think that tobacco affects other people's health. These can be sensitive topics, and it is important to keep in mind that the way you approach your patients about these issues will have a big impact on how your advice, concerns, and policies. In general, it is not useful to confront questions about their tobacco habits, as that approach is usually not well received by patients and may interfere with the ability to counsel them effectively. Watch what happens as this provides us more confrontation.
Sorry. My bad. Wrong button.
have opportunities to counsel patients about health-related behaviors. As a medical professional, you have a responsibility to talk to your patients about tobacco use and how it affects their health. At times, you will also have a responsibility to talk to them about how secondhand exposure to their tobacco smoke affects other people's health. These can be sensitive topics, and it is important to keep in mind that the way you approach your patients about these issues will have a big impact on how your advice and concerns are received. In general, it is not useful to confront or scold your patients about their tobacco habits, as that approach is usually not well received by patients and may interfere with your ability to counsel them effectively. Watch what happens as this provider becomes more and more confrontational in her warnings about tobacco use and her advice to quit smoking.
Okay, so I wrote a prescription for an antibiotic for Aiden that should help with the ear infection, but in looking through the chart, I mean, it seems like he's had 6 or 7 of these just in the past year or so.
Yeah.
That's really a big problem.
Yeah, it's pretty stressful for both of us. I think it's really upset.
Well, one of the primary risk factors for multiple ear infections in kids is actually smoke exposure. Are you smoking?
Yeah, I do smoke, but I don't smoke around him. I try really hard not to smoke around him.
Well, the fact that he's having these ear infections is indicating to me that he is being exposed to smoke. And so what can you tell me about that?
I don't know. I mean, I try really hard not to smoke around him. I don't smoke in the car. When he's home, I go outside to smoke. I mean, I know it's bad, and I know it's bad for him, so I don't want him to be around it, so I try really hard.
I really need you to quit smoking, both for your health and for Aiden. Did you know smoking around your child is associated not only with ear infections, it could get to the point where you have to put tubes in his ears pretty shortly here, but also things like vitamin C deficiency, cavities, like dental cavities, behavior problems, asthma, other upper respiratory infections. It's really putting him at a lot of risk. In addition to that, kids of smokers end up smoking themselves. Do you want him to grow up to be a smoker?
No, but I don't smoke. I've thought about quitting, but it's really hard, so I just don't know how to do it.
Well, now's the time to quit. It's really gotten to the point where you can't keep smoking. Not only for him, like I said, but also for you. You're putting yourself at risk for lung cancer, for emphysema, for oral cancers, for heart disease, for all kinds of things.
I know. I've heard, people have told me before, I've heard all that. I just don't know how to do it. How am I supposed to quit? It's so hard.
Well, there's all kinds of things you can use now. It's not as hard as it used to be. You can use nicotine replacement. There's patches, there's lozenges, there's gum, there's the inhaler, there's nasal spray. We can talk about medications. You can try Chantix, you can try Zyban. There's quit smoking groups you can go to. There's hotlines you can call.
I just don't have time
There's
for
no
any of
reason
that.
why you shouldn't be able to quit. This is really important.
I understand that. I know it is. I mean, everybody has problems, right? It's just really, it's really, really hard.
Well, what can be more important to you than the health of your child?
I don't know.
I really need you to tell me that you're going to quit smoking. This is really important.
I'll go look at all those things and I'll find, I guess I'll try to find something and I'll talk to my doctor about it.
Okay, well, I think you really need to think about this seriously. Like I said, it's really putting yourself and your child in danger.
Okay. Whatever. Okay.
Okay.
By starting the interaction with an accusatory question, "Are you smoking?"
Yeah. Okay, I want to hear then. Where was the sustained talk? So for you guys over here, what did you hear? Sustained talk?
I'll try. When she said I'll try, she doesn't have
I don't smoke around him.
That's a lot of things.
So yeah, no, you guys need to move down here. So there was not a lot of, what'd you guys hear? Did you hear any sustained talk?
Everyone has problems.
Say that again?
Everyone has problems.
Yeah, okay, what else?
It's really hard.
It's really hard.
No time.
No time. Who said that? Good for you. Yeah, you don't have time. What?
I don't know what to do.
You don't know what to do. Heard this before. You missed the piece where she said, yeah, whatever. Yeah, I would code whatever existing talk. Okay, great, good. So change talk, what change talk did you guys hear?
She's thought about quitting.
Louder?
She's thought about quitting.
So she's thought about quitting. What else?
Start looking at those things and start to, I look at those things.
She was sarcastic. Okay. What else?
I know it's bad.
I'm sorry.
I know it's bad.
I know it's bad. Oh, you were, never mind. You're in the sustain talk section. Oh. Yeah.
She said, I try, I really have.
Uh-huh.
She didn't want smoke to be around the baby.
Right. She knows that it's bad. She knows it's bad for the baby. Yeah. So you're getting the reasons for the the desire, the reason, the need. Where's the ability? Did you hear any ability?
She said, I don't know how.
Right, but she's done it before. So she did stop smoking before when she was pregnant. So she's been able to do that. So that's something that you've got there to build on. And it wasn't just for a day or 2 days. So she did it when she was pregnant. So she had at least probably 6 months of, yeah.
And she's able to modify her behavior, not smoking in the car.
Exactly. So she's already done some harm reduction. Yeah. Great. Okay. What did you guys hear? There was what?
Shaming.
Shaming. Okay.
Rapid advice.
A lot of advice. Yes. What else?
Very pushy.
Wait.
Directions.
Giving directions?
Very pushy.
Pushy.
I said direction.
Giving directions?
I need you to quit.
I need you to quit. Okay. What else?
Undermining the importance of her child's health to her.
Mm-hmm. Yeah?
Telling her the cons rather than getting her to come up with her own cons.
Yeah. The physician's making the reasons for change instead of the client. And you always, in MI, you want the client making their own reasons for change. And she gave you some change talk. The physician just didn't know what to do with it. She didn't hear it, and she didn't know what to do with it. Yeah.
She said there's like no reason not to quit, super easy to quit. That could make her feel powerless if she's not able to.
Right. She was discounting the reasons that she, yeah. Okay.
She never asked permission.
She never asked permission. I tell you though, it's interesting. I went for my annual physical last July, and my doc didn't ask permission either, and she told me, you need to lose weight. And then I went to my endocrinologist in October. He said the same thing, you need to lose weight. But I accepted it very well because I agreed with them. But yeah, there's ways to do this, and neither one of my physicians were particularly skilled either. So we're going to watch, hopefully, a more effective way. So over here, what I want you guys to listen for is, so the back 2 tiers, and my spirit again, you guys listen for, is she evoking at all? And if so, what was the open question she asked to evoke? Okay? And you guys, see if you hear, again, any sustained talk over here on these 2 tiers, and then change talk here, right?
Watch what happens this time when the provider cues into what the parent is saying, emphasizes with her situation, and attempts to work with the parent to find a solution that fits her needs.
So I wrote a prescription for antibiotics for Aiden. Okay. I did want to talk to you though. I'm a little bit concerned looking through his chart at how many ear infections he's had recently, and I noticed that you had checked the box that someone's smoking in the home. So I was wondering if you can tell me a little more about that.
Well, it's just me and him, and I do smoke. I try really hard not to smoke around him, but I've been smoking for 10 years, except when I was pregnant with him. But everything, it's so stressful being a single mom and having a full-time job, and so it's just, that's why I started smoking again.
You have a lot of things going on, and smoking's kind of a way to relax and de-stress.
Yes, yeah. Some people have a glass of wine, I have a cigarette.
Sure. And it sounds like you're trying not to smoke around him. Why did you make that decision?
I know it's not good for him. I mean, I've read those things about ear infections and asthma and stuff, but other kids have ear infections and their parents don't smoke.
So on the one hand, you're worried about how your smoking might be affecting him, and on the other hand, you're not so sure if it's really the smoking that's causing these problems.
Right, yeah. I mean, he doesn't have asthma. He hasn't had a lot of other problems that his other friends have. So, and I've thought about quitting before in the past, but I just don't see how it's possible right now.
What made you decide to quit smoking when you were pregnant?
Well, he was inside me and we were sharing everything, and I knew that he would get some of that, and I just didn't think I could live with myself if something happened to him.
Right now, though, it feels almost too difficult to even manage or even to try.
Yeah, exactly.
How were you successful when you quit before?
I don't know. I think about it now, I don't even know how I did it. I just did it. You know, I just couldn't imagine like him not being born or going into labor early and him having problems and stuff like that, all the stuff that they talk about with women who smoke. So that was just enough to say, okay, you know what, I'm not going to risk that. So
the risks were so scary then that you were able to stop, but
yeah.
They don't feel as scary to you now.
No, I mean, we're two separate people, and like I said, I try really hard not to smoke around him. I'm pretty good about that. I don't let other people smoke around him. So
You're doing the best you can do.
Yes. Yeah.
Okay, but it sounds to me too like part of you really does want to quit.
Yeah, I know that I need to, and I keep, every new year I say, okay, this year I'm going to quit smoking, but then something happens and it just doesn't.
It's on your to-do list, it's just not making it to the top.
Yeah.
If you did decide to quit, on a scale of 1 to 10, where 1 is not at all confident, you don't think you could do it, and 10 is you feel pretty certain that you could, where do you think you fall right now?
Probably like a 5. Kind of in the unsure area. Like, I know I've done it before, so I know I can do it, but at the same time, it just seems really hard, and it's not the same situation.
Well, what made you say 5 rather than 2 or 3?
I know all the ways it's bad for me, and I don't want him to grow up thinking that it's okay to smoke. I don't want him to use any kind of, I don't want him to chew or anything like that. So I know I need to, especially before he gets old enough to understand what mommy's doing, but I just don't know if I can do it.
Okay. So it sounds like you have a lot of reasons why you'd like to quit. You have been successful quitting in the past, and right now you're just feeling a little bit hesitant about your ability to do it.
Yeah.
Where do you think we should go from here?
I don't know. I'd like some help. I just don't know what kind of help I need.
Sure. So. Well, if you'd be interested, that's something I can definitely talk to you about. There are a lot of new options that can actually help people be way more successful in their attempt at quitting. There's different medications you can try.
I don't like medicine.
Okay. There's also a lot of support groups and classes that you can take where you have other people to go through it with you, and sometimes just having that support can be a big part of it, especially for people like you where smoking is such a stress reliever.
That sounds nice, but I'm not sure if I have the time for all that.
Sure. It feels like something that would take up a lot of time and maybe not fit into your life. I wonder if we could talk about some options that might fit into your life.
That would be really nice.
Okay, well, if you're willing, then we could set up another appointment where you could come in and we could talk more about that.
I would like that. That would be great.
Great.
Thank you.
Sure.
This time, the provider had the same agenda, to talk to this parent about the dangers of secondhand smoke and to counsel her to quit smoking. However, this time the provider's focus was on the parent's own view of the issue. By giving the parent an opportunity to reflect on her situation, the provider was able to elicit reasons for change from the parent herself. There was no need to lecture or scold because the parent was making her own case against smoking. Many times, our patients already have the information that we try to give them. What they really need is someone to listen to them and to help them sort out a plan that will fit in their life. By accepting and respecting our patients, even with their faults, we communicate our genuine desire to help them make positive changes in their lives. During this interaction, the provider demonstrated that she understood the parent's struggle and that she still wanted to help. As a result, this single parent found she finally had someone on her team. This increased both her interest and willingness to try working further with the provider to find a solution that would fit in her life.
All right. Let's see if I can remember what I had you guys do. You guys did the same things last time, right? What did you hear from the physician this time?
Reflection.
So some reflections, yeah.
She highlighted the ambivalence.
Yes.
Decisional balance.
Mm-hmm.
Open-ended questions.
Open question, yeah.
She asked her on a scale of 1 to 10, and then when the lady told her 5, she kind of strengthened her reasons, got the lady talking about the reasons why it was important by saying 1 out of 2 or 3.
Right, right.
She asked how she was successful the first time.
Mm-hmm. So she was pulling for confidence there, pulling for ability. Okay? Yeah.
She always went back to why she wanted to quit, even if she talked about the reasons why she did want to. She always went back to why.
Mm-hmm.
She gave her affirmation.
What was it?
Like having a little bit of empathy for what she goes through, why she does the things she does.
I'm sorry, say that one more time.
She gave her a little bit of empathy as to what she goes through, like her explanations as to why she smokes.
Mm-hmm. Yeah.
It's hard.
So she was empathic. Mm-hmm. Yeah. Yeah. So you heard the ambivalence, I hope. Some of you did. Yes.
Can she offer change options?
No shame.
Where do you think we could go?
Yeah, and what she did, so she asked permission, the client nodded, but then she started giving her way too much. And then the client put up a little bit of a, did you feel that? Did you notice it? And then the physician backed off. Yeah. Something else was said that I was trying to, okay, and what were you guys listening for? Okay, what did you hear?
Questions. What made you stop the first time?
Huh? What? Yeah, what else?
Tell me more.
Tell me more.
How were you successful?
Oh my gosh, it's almost like you're plants or something. What? How? Tell me about. Those are the 3 ways typical ways we start an open question. What I encourage my staff to do is put these like in big what, how, tell me about, and put it somewhere where the clients can't see it, but that they can see it, to prompt them to be asking these open questions. What, how, tell me about. Yeah, good. Yes.
She said, where do you think we should go from here? That
Yes.
was a nice open with the direction.
Right. And because, so what she felt like, what Lisa Merlo felt like was that this had enough resolution, the ambivalence had resolved enough in the direction of change for her to see, can we move into preparation? And so when you feel that way, when you assess it that way, then you ask a key question.
Still have the issues.
Right?
And see how it's possible right now.
Yeah.
How
Yeah. Say that louder.
I want to quit. I want to quit.
Yeah, that's change talk. That's not sustained talk. Yeah. Yeah.
She mentioned that she's been smoking already for 10 years.
Yeah. And she had a year's worth of, 6 months worth of quit time probably. Yeah. And then again, when the information started coming, one of the reasons that she gave was time. So you have to hear that. And so what Lisa Merlo did, though, was she did reflect back some of the sustained talk. Not a lot, but she did want her to know that she heard her. The change talk got much more emphasis. So what change talk did you guys hear?
Try not to smoke around the baby.
I'd like some help.
What?
I'd like some help.
Louder?
I'd like some help.
Okay, what else?
I know it's not good for me.
I know it's not good for me. What? What else?
I'm gonna quit. I need to quit.
I need to quit. I've done it before.
I know I can do it.
I know I can do it.
And I think giving a 5 counts. She could give it a 0 because she didn't want to quit. So by giving it a 5, it's definitely important.
Right, so you see the ambivalence. It's really clear. Yeah. Good. You guys were all really good at picking out the sustained talk and the change talk. So she got a lot of, what was Lisa Merlo doing to get and keep this change talk going? Evoking, using open questions, and then what else? Reflections. How did she affirm? I don't recall the affirm. That doesn't mean it wasn't there, but I don't recall it. Oh, you've been successful in the past, maybe? Yeah.
I don't remember how she said, but she was affirming how she understood that she doesn't have a lot of time as a single parent, but there's other things maybe that might work.
See, I wouldn't call that an affirm. I would just, yeah, I wouldn't call that an affirm. So affirm, again, is positive reinforcement of a particular value or behavior. Right. Please.
So when she was doing some of the sustained talk, she reflected back to her this idea of, I see that you're doing the best that you can. I'm not even sure if that's what she was saying or she was reflecting back. That I understand that you understand that you're doing the best you can.
Yeah.
And I was wondering how that was strengthening.
It wasn't?
The sustained talk, or maybe how it was softening.
Well, oh yeah. You know, it would fall probably into that category of strengthening. But again, you know, when you're in that quadrant of the decisional balance and you're trying to engage somebody, you can't totally ignore the sustained talk. So you've got to let them know that you've heard somehow. But if you really think about this session, though, that 7 minutes or whatever, the bulk of it was really around the change talk.
That seems like accurate empathy.
Say that louder.
That seemed like accurate empathy to me when she said that.
Yeah, so there's the words which fall into sort of identifying the language where it falls into. Open question, closed question, blah, blah, blah. But then there's the philosophical basis behind it, which is the MI spirit. That's where the empathy falls. Because I can say to you, shut up. And there's a way I can say that would be harsh and mean. And then there's a way I can say it that's a way that two girlfriends might say, oh, shut up. You know? So it depends on sort of where that's coming from, the context and relationship and moral law. And in this instance, the client-centered piece. All right. So we have 40 minutes left. We're going to go through then. Isn't this a beautiful picture? Don't you wish you were there? we ask open-ended questions if we're not getting change talk. It's not a hard and fast rule, but it's pretty much the standard. No change talk, open question. Trying to elicit, trying to evoke. Open-ended questions, again, what are they? What do they start with? All right. You guys over here, what does it start with? Good, thank you. All right.
And where should we go from here?
Yeah, that's towards the end of contemplation. Affirming, we've already talked about that. Oh, yes, this is important. So when we're asking open questions, we don't go back to like, how do you think your being abused as a child has to do with your, what do you think, it has to do with your smoking cigarettes? So we're not interested in that far back. What we are interested in is Lisa Merlot's change, her quit attempts and her quit successes. So we're interested in something around the behavior that historically might be abuse. So we're interested in what are the disadvantages of the current behavior. So again, we've got our decisional balance here. Here's the current behavior and the pluses that we want to kind of stay a little away from. What are the disadvantages? What are some of the not so good things? What worries do you have? What concerns do you have? That was how Lisa Merlot opened that session, wasn't it? I think using the word worry or concern, something like that. If you were to make the change, what benefits might you see? How would you feel if you were to lose weight? So this is that future. If you were to make this change, what might the benefits be? What might the positives be? What makes you feel that now is a good time to try something different? That's a really nice kind of question, and sometimes I'll use it and it throws people off a little bit, and that makes them stop and think. And then that gives you something else to work with. And then here's the one, remind me your name again? Yeah?
Oh, Yvonne.
Yvonne? So what would you like to do about this? Yeah, it's that next step kind of question. So the disadvantages of the current situation, and the pros of if you were to make a change, the pros of the other situation, of the new situation, new behavior. Okay. So the other one, so OR's open questions, A, affirming, R, reflections. One time I had a staff member, I still have her, but so she had had coaching for a while, maybe up to a year. And I happened to slip into one of the folders in SharePoint and listen to one of her sessions. I wasn't her coach. And So I asked her, I said, well, how's it going? How's your online coaching going? Oh, it's going really well. I said, what do you think you're doing? What do you think you're doing well? I'm just doing reflections. That's almost all I'm doing. I'm not asking any closed questions. There's some open questions, but it's pretty much all reflections. No, not at all. It was almost solidly closed questions. I have a seasoned clinician who works for me who will remain nameless, and this person has been avoiding coaching, and they think that they are asking, that they're offering reflections. This person really believes it, but he's not. He's asking closed questions. So my point there is that we are not good observers of what we're doing. Where it can get really confusing is this difference between a closed question and a reflection. And it's in the intonation largely. So there's a difference between so you're going to go buy groceries this afternoon, which is what? Closed question versus you're going to go buy groceries this afternoon. And what is that? It's a reflection. So it's flat. So it's the same thing in a way. So reflections are making a guess as to what the meaning is. It has to be flat. If you are in your 20s and maybe 30s, you may have a tendency to turn up over half of what you're saying and not even be questions really. You know what I mean? I can't even do it. So you know what I'm talking about, yeah. So many young women particularly turn up their statements at the end, and that makes it sound like a question.
Yeah, so it's more about tone.
Yeah. Yeah. Although, yes. Although it's not exactly. Yeah.
That just makes me think of a challenge or something, and this is kind of a side note, but particularly folks that work in the medical field, we use translators, for different languages, and I know that they're very professional in, translating the words, but I can kind of see now from what you're saying that this whole piece can very possibly get very lost. Correct?
Right. It could, yeah. Although, it doesn't, this has been brought up at annual MI trainers conferences. I don't think there's been any resolution. The research that's been done around reflections is flat. It's not turned up at the end. There is a difference. Open questions are designed to evoke what's missing, what you're not hearing. Whereas reflections takes what you're hearing and is building on that. And it builds on it either by simply repeating, and you don't want to do this very many times, because then people start to say, why are you repeating everything I say? So you want to have some degree of skill with your reflections. There are so many different kinds of reflections. There are amplified reflections, double-sided reflections. You can do just a simple rephrasing. You can paraphrase, which means you're reflecting back something that has some additional meaning that wasn't exactly in the words, but was underneath it maybe. Or you can reflect feeling. I hesitate to say that with people who are therapists. Because some of you may have been trained at a time where, how does that make you feel? I would say is overused. So in MI though, we don't do this so much. We don't overuse this. It really is, I would say use sparingly. Uh-oh. I wonder what the heck that was. All right. So I gave you guys a handout, another handout. What I'd like is for us to walk through this. And I need a volunteer. I need a volunteer. I need a volunteer. Somebody who has some pipes on them, can speak loudly. Who might that be? All right, come on up. So I want us to walk through this. Give me a second to think about our non-process. really want us to do a little bit of deeper analysis here. Sometimes people give you sentences where, like there's a sentence I think about a lot, and I play with it a lot. It's a mom who has been beating her kids and wants to stop. So I didn't do what I normally would. Instead, I stopped myself, went outside and took a walk, and thought about what I might do instead. So you've got 4 chunks in that sentence, 4 pieces. And so how do you decide what to focus on in an MI session, or in a particular sentence, in fact? So you'll have some sustained talk, possibly. If not, then you're going to ask an open question. If you've got some change talk there, so sustained talk, what are you going to do with that? You're going to try to ignore it, maybe. Then you're listening for change talk. If it's not there, you're going to evoke it. If it is there, you're going to reflect. So sometimes the hardest part is not getting caught by the sustained talk. Not going back to your inclination, which might be to explore a person's childhood or their history. So let's see what shows up in this then. So I'm going to be the practitioner, and you're going to be the client, all right? You can just listen this first time and see what you hear, and then we'll take a look at it. So tell me about why you're coming to a Voc Rehab Agency now.
What do you mean?
A little louder.
What do you mean?
So what is it about right now that made this feel like it was the right time?
I need to get back to work to support my family. My pain is better, so I need to do something.
Feeling better allows you to think about working again.
Yeah, I mean, 2 months ago I would have still worried about the finances, but I was just too uncomfortable to do anything.
So you're more comfortable now, and that opens the door then to some of these other things that you've worried about.
I don't want my wife to work so many hours. She's really had to do extra, and she's got her own health problems. And I just want to take care of my family instead of laying around at home.
You are not someone who likes being idle. You're a provider. And it really bothers you that you've been unable to provide. And it hurts even more watching the cost to your wife.
Exactly. I've worked my whole life, and then I hurt my back. And all of a sudden, I can't do anything. I need to be doing something. I just haven't been able to, and that has left me pretty down.
So you're here now because you can be. 2 months ago, you couldn't have done it. But now that you can, it's really important, maybe critical, for you to begin caring for your family and your wife again by working. It's who you are.
Let me see if I've got this so far. You have been feeling better. That's you.
I didn't like the second one, so I did the first one. Okay. So let's talk about this. This is a typical. This is a typical kind of what brings you here. But what was different about this is, if we had asked this guy, what brings you here today, he would say, a job. So throwing that, what brings you here now, what brings you here to this agency now, and he didn't understand that. But then, it really opened that up to, and you don't do that with your client every time they come in. But I do that periodically. You know, why now? So then he said, I need to get back to work to support my family. My pain is better, and so I need to do something. So you would have had some choices there. What are you going to focus on? I need to support my family, my pain is better, or I need to do something. Yeah.
Well, there's 3 things I would kind of try to find out what's the most important thing to that person.
So he's giving me some change talk already. So this is change talk. And so you're going to want to reflect. how would you decide what aspect of that to focus on so that you could reflect? And of course, this has to be done instantaneously.
But what is he ready to do, or I mean, it says I need to do something.
Yeah. So the deal here is you have to think fast. I need to get back to work to support my family. My pain is better, and so I need to do something. So what you know from that is that this guy's pain has really been bad enough that he hasn't been able to work. So it's thinking, where's the emotion? Where's the energy around this? Where can I? And so that's what he does, or the practitioner does. Feeling better allows you to think about working again. Now that might have fallen on its face, who knows? But it seemed to have worked. 2 months ago, I would have worried about the finances, but I was just too uncomfortable to do anything. And so it appears that it was a good reflection. So you're still getting change talk here. 2 months ago, I would have still worried about the finances, but I was just too uncomfortable to do anything. So now he's there in your office. You're more comfortable now. And I love this language, and that opens the door to some of these other things you've worried about. So again, it's this worried language, really sticking with that. So this guy's he's not been working, and he's not been working for some particular reasons, and he's thinking about going back to work. I don't know how much ambivalence there is at all. To me, it seems like he's in preparation, that he's there, trying to, but, you know, this is the first time, so you're feeling this person out a little bit. Are there any negatives to the current behavior? Well, heck yeah. He's not helping his wife financially. He's not bringing the money. He doesn't like just kind of hanging around doing nothing. So the other side of this then is if we were to get a job, and then what might be the not so good thing about getting a job? So we're not there yet. We're here pretty solidly. We're a little bit here. He wants to work, and he's starting to tell you the reasons why he needs to work. And then so he's concerned about his wife working so many hours. She's done extra. She has health problems. He wants to be the one taking care of the family instead of laying around the house. And then she affirms him. I affirm him. You're not someone who likes being idle. So there's a value statement there. You're a provider. And then as we go down towards the bottom, there's a summary there. And that's the last part of the oars. So you've got open questions at the beginning. There's an affirm in here. There's reflections, a couple of them. And then there'll be a summary. And you can summarize in a session with your clients a couple of times. You know, it's like, are we about to shift gears a little bit, or do I want to wrap this up and see where it takes us? And so this is wrapping it up, seeing where it takes us. So you're here now because you can be. 2 months ago you couldn't have done it, but now that you can, it's really important for you to begin caring for your family and your wife again by working. It's who you are. Questions about this? Yeah.
So do you have any recommendations on open-ended questions where you can start out with a patient who's not there willingly and doesn't necessarily think they have a problem, but has been referred to by their doctor?
Yeah. You know, I don't want to, there's a really great place to look for that. So SAMHSA, the SAMHSA website, If you go and look for tips 35, capital TIP 35, it's an old book that is motivational interviewing and the transtheoretical model blended together. So there are some pieces in there on reflections, and all of the reflections are in response to that kind of sustained talk that you're talking about. I don't understand why I'm here. And it gives you 3 or 4 different options. And what I tell my people who come to my workshop is they ought to chant that stuff. They ought to print it out, chant it, like one every day, over and over and over again. Because then when you hear it come out of a client's mouth, you've got some things you can say. The other stuff, some of that stuff is really old, but there's some good stuff, and it's free. You can download it.
I have a question.
Yes, ma'am.
Even looking at this, you have the question, how did you decide to make this change?
Right.
It's a really confusing question to me. Like, what do you mean? How did I decide? Like, I didn't know what to do.
Yeah. Well, sometimes there's either, so I'll tell you for myself, when my 2 docs over a short period of time said you need to lose weight again, you need to lose weight. So if you would ask me that question, how did you decide to sort of get back on the exercise horse? Or how did you decide to start getting serious about it? Then I would say, well, these 2 guys, one female and one male told me. But I'm sure those of you who did this exercise might be able to also say, how did you decide? Oftentimes there might be one thing, but there might be 4 things that just kind of come together, coalesce at a certain point in time. Unless you are just eager to shower at the gym. Yeah. Who was speaking?
No, I was just going to say, I think I'm very literal.
Yeah.
And so how did you mean that I go, pros and cons? And so not to be literally, how did you decide, what was your decision-making process?
Yeah.
But more,
what was
the factors?
Yeah. What was it that brought you here? Yeah. That had you, It's I get what you're saying. It's not so, yes.
It kind of, I had a similar thought too, but I think I see it in the example that you gave with the man, that he was saying that his pain level improved, and it made me think about this idea of confidence and ability.
Yeah.
That somehow, because he felt like the pain was no longer there the way that it was before, now he had more confidence and he had the ability also to go out and kind of make or start to meditate. So,
and he has the reasons.
Right.
Yeah. Because you can have the ability and confidence and not have the reasons.
Well, yeah.
All right. Hi. Yeah?
So my population is older adults, and then probably average age.
Older than me?
Average age of clients.
Don't walk into that one.
The average age is like 85 and older. Yeah, and how can you use this motivational interview among these older adults, because they may not be able to physically change any of their ability, and they even cognitively as well. But the majority of them are very depressed. So I would like to use this motivational interview to alleviate their depression.
So MI is really around behavior change. So what you would want to use the MI for, there would be 2 pieces. One, to have them interested in, to have them be wanting to do something about their depression. And that doing something would either be therapy or it would be being more active or being on psychotropics. So the MI would be that piece to get them ready to take action. And those would be the action steps.
They may not even recognize their depressed.
Right, right. And so that's where, yes, so then that's where you can use the MI to start trying to pull from them, and then you reflect, and then you may give a little information, a little advice, and things like that. Yeah. But MI in and of itself will not, it can be useful to help get people to take action, but it's not going to, that they have to take the action. You've got to help get them there to that point, but then something else has to happen in order to work on it.
So the MI can be used to recognize that they're depressed.
Yeah, yeah, you can use that up front, yeah. What are their concerns? What do they think about their crime? What do they think about their lack of energy? What do they know about depression? You know? Yeah.
I have a question. You had mentioned about feelings having its own place within MI, but I'm wondering, as people we've been giving examples, there's an element of identifying the emotion that can feed into and support the change in the behavior.
Very much so.
So is that, I mean, do we want to, should we utilize that as well?
Yes, yes. And you typically do that in a reflection. That makes you sad. And that upsets you. Goes in that kind of way, as opposed to that, and how does that make you feel? Although you could do that occasionally. I'm not one of the, you're probably asking the wrong person, I'm not one of those kind of, you know, I used to label those the F word, you know, just feelings, keep it out here. So I still have some aspects of that in myself. But yes, you can do it through reflections. But, you know, not overkill. All right, I think what I want to do is watch a video. Let's see how much time we have. Not so much. All right, so we're gonna, let's see what we're gonna do here. Okay. Again, what I think I want you to do is, there are a whole bunch of videos that are really good videos. This is not inexpensive. It's probably around 170 bucks through this company called the Change Companies. But half of it is discussion with Bill Miller and Steve Rolnick and Terry Moyers, and the other half is these videos. They made these for the 3rd edition of the book. So let's see, I'd really like to listen to this one, but it's too long. Okay, we can't do that one. Let's go back. Let's listen to, all right, stop it. And what Steve Rolnick does with it. Then listen for the change talk if there's any. Open questions and reflections. All right?
Thank you so much for coming up this morning.
You're welcome. Thanks for having me.
I can see that
Oh, it took quite a bit of planning and effort to get here, but I'm here, so.
And I understand that you were referred from Dr. Ross, who's about to operate on you for a second time.
Yes, indeed.
This is our first meeting. It will be brief, but I am here to see you again if that's what you so choose at the end of this or at any time in the future. And really, you know, I wanted to welcome you and offer you the opportunity just to tell me what you've been through and how you're feeling about coming up here this morning.
Well, to be honest, I'm not really quite certain why I'm here. I don't see the link between smoking and my surgery. I know I need a second procedure right now, so there are some thoughts that are going through my head about the whole situation that I might not be getting the whole story.
Right, right. And so in that sense, you're a little bit unsure why you're here because you've been asked to come down here by Dr. Ross, yet you don't really understand what actually went wrong the first time round with the surgery.
Exactly, exactly.
Right.
So that raises
Right.
other questions.
Right, which must make you feel to some extent a little bit resentful about what's quite going on here.
A little bit. No offense to you or,
Sure,
or what you do
sure,
here.
sure.
I believe there are people that need to quit smoking,
Sure.
you know, if it's hurting them. I don't think that's me, but I'm here. I'm here to listen.
Sure. Okay, and could I ask you, you know, how you feel about your smoking?
I enjoy it.
I mean, you're here now, and we've got a few minutes, and I'm just wondering what would make the most sense to you as to how we spend our time? Because that's what I'd like to know is how you feel about your smoking, but...
Well, I do enjoy it. First off, I use it to relieve my stress. I use it in social situations. I use it when I feel lonely. I can go outside and it's always there for me. I do know that it's probably in my best interest to quit.
Sure.
But I do also know you can get hit by a bus, you know, especially in Albuquerque.
Sure, sure. So you're saying to me your smoking is something that you actually enjoy?
To be honest, it's putting a big dent in my pocket. It's an expensive habit.
Right, so it costs you?
Oh, absolutely, absolutely. Not to mention, in the morning I cough. I have a really, really bad cough.
Right, right.
So that concerns me.
Right, so there's something about your body feeling a bit challenged by this.
Yeah. Also, well, my cardio fitness, you know, it's affecting my game on the field too. So yeah, I wanna do well for my team.
And what do you notice about the effect of smoking on your sport?
Well, I know that people are running around me all the time, and I can't keep up, and that's it's not a good feeling. It's not a good feeling at all.
Right. So you notice it on the rugby field?
Yes, I do. A big change since.
Right. Since how long?
Well, it's been 6 years.
Right.
And before that, when I was playing, I could run the full 80 minutes.
Right.
Now I feign injuries sometimes. Not this time.
No, but because you feel so out of puff.
Yes, absolutely.
And you've noticed the last few years that that's been increasing.
Yeah, I'm not on the select side anymore, so.
Right, right. So you're starting to lose some of your fitness, and you reckon this might be linked to the smoking?
It makes sense.
Right.
It's smoke, and human beings, I don't believe, are supposed to.
Right. So there's stuff you get out of this, but on the other hand, you notice the effect on your chest in the morning.
Absolutely.
And you notice it in the rest of your body when you try and exert yourself.
Yes, I do. I do.
Is there anything else about it that you're concerned about that you haven't mentioned?
Well, there is a history of heart disease in my family.
Right, right.
And, well, scientists say that it's bad for your heart. I can see that. So.
And so there's a bit of a worry you have about what the condition of your heart might be.
Yes, however, it's a subject I kind of avoid with my doctor. So.
Right, right. And yet here you've had a doctor who's about to operate on you.
Yeah.
And it's like you can see the connection and he can see the connection.
Yeah, I don't want to be stupid.
Yeah.
being ignorant's one thing, but just being stupid.
Yeah, so you can sort of see the connection, but it's not necessarily something that's easy to talk about with a surgeon or indeed in a situation like this. Eh? Yeah.
Yeah.
I wonder where that leaves you now.
Well, I'm here, so obviously I do want to do something about it. What that is right now, I'm not sure. I know there are aids out there, such as the patch. I've seen people wear the patch and they swear by it, and they're almost proud of it. See, here's my patch.
Yeah, yeah.
Nicotine gum, all that good stuff.
I was going to ask you about that. I mean, how much do you know about those kind of stop smoking aids?
Not much, not much. I've never really tried to approach quitting. I didn't see the need, but...
Right. And I mean, that'll be a decision that you take for yourself, and I'm not suggesting you make that, but what is it that you'd most like to know about stop smoking aids? I mean, is there any piece of that puzzle that I can help you with?
If I were to choose one, I definitely want to know how the side effects are going to affect me.
Right.
That's one thing I worry about with drugs that I see on TV, especially the new ones. The side effects are anything from sexual dysfunction to you know, ulcers. So,
and if you're going to make a decision to stop smoking, you want to make sure that you get an aid that's going to suit you and is not going to have side effects.
Exactly. What's the point of quitting smoking if the thing that is helping you quit is messing you up? So,
and perhaps I can just let you know that there is quite a range of these aids. Some of them you're quite right, like bupropion. That is a drug that can have side effects, and it doesn't contain any nicotine. Okay, so that's one kind of aid. Okay, but then there are others that contain nicotine, like a patch or gum, that really are devices for helping you tail off the withdrawal symptoms gently. So there's broadly those two kinds of aids, and the success rates of them are reasonably good. But it sounds like you're particularly concerned about a drug that might have side effects.
That is my main concern. If I could take something that could help me quit, I could probably embrace that as long as it didn't affect me adversely, because I have enough problems.
Sure. And so if you could avoid the side effects, you might even consider taking one of these supporting aids that didn't have side effects.
I might give it a chance, and also cost is a factor as well. You know, if it's expensive to do, then well, I'm back where I started.
Exactly.
Maybe my health will get better, but I'll still be...
Exactly, because that was one of your concerns about the smoking in the first place.
Absolutely.
So you might have to make some kind of financial sacrifice to quit smoking, and you're concerned about that.
Sure, but in the long run, I think, I know, I'm probably just trying to enable myself. But yeah, I guess that my number one concern would be just the side effects.
Right. Okay, let me see if I can just summarize what we've said so far, because we're going to be stopping the interview quite soon, okay?
Okay.
It's something that is important to you, and you definitely get benefits from it. On the other hand, you've noticed its effects on your cardiovascular health with a history of heart disease. And if you could find some kind of support aid that didn't have side effects and wasn't too expensive, you might be prepared to go for it.
I think I might be able to give that a try.
You might even give it a try.
Might even give it a try, yeah. Maybe I'll make the select site again.
So we've just scratched the surface on this, and I hope you have a little bit of a clue as to what MI is, a little bit more of a sense as to what its purpose is around behavior change largely, but not completely. You can use MI as an overall counseling style. You have to have a target behavior, and you've got to be listening for discord, ambivalence, change talks. At the same time, you have to be really skilled in your open questions and your reflections. All right, and I think you guys know where I am. I'm at Search, Homeless Services, and you can find us online if you want to email me. And thank you very much.